Morning, team. It's Saturday morning, a little bit earlier than what I wanted to wake up to do. I wanted to get some stuff accomplished. But I know there's been some question about how to bring our 99309s up to a 99310. And so I feel like it's an easy enough task to do. So I thought that we'd start Saturday morning, at least for me, versus a cancer spot that they removed and the Band-Aid didn't look good. So ignore that. Ignore the lack of makeup because it's Saturday morning. But I think I've got some good things to show you. So I wanted to get started. First of all, I'm using a computer system that's different than what we're using TrueRCM. Rationale behind that is I want to be able to show you what's going on, and I don't want you to be able to see the patient's name. So other than that, think about most computer systems, most documentation. You've got your wounds, you've got your doctor's notes, you've got your psychiatry notes, your psychology notes. Most of our notes look the same. So it's going to look a lot alike, and I'm going to pause between patients. So this might be a long video. The difference between this is it's going to change you from a 99309 to a 99310 and get not only your numbers up, but show you how you can make this work. So a lot of pausing in here as I pull over screens and try to maintain patient confidentiality as far as the notes go. So let's get started. Again, if you don't feel like this is something that you want to do, you're okay with the 99309s, that's great. Those that want the 99310s want to be on this. You want to spend an hour with me, or heaven forbid, any longer than that on a Saturday morning. I'm sure you're watching it later on in the day, but this is going to be good information that you don't want to miss. Okay, so I have a basic note that I'm adjusting to make sure that it meets all of the criteria. So it's a 69-year-old male with a primary diagnosis of dementia, BPH, chronic retention, and spinal stenosis. Again, many times I just tell you a primary diagnosis can be one, but I do give you the option if you want to do that run-on sentence and give a couple of primary diagnoses. That's okay. They'll be discussed during this visit. Chief complaint is cyanitis. My expectation is that your chief complaint is going to be your first assessment and plan. So then, of course, we've jumped into the snippet, the ever-living snippet that always causes problems because it says blood glucose reviewed and all of this other stuff that we don't do. So this one is just saying that they reconcile the meds. The vital signs were reviewed, the blood pressure log was reviewed, therapy progress was reviewed, and labs. So the patient, as she starts off, patient having skin issues wants a Benadryl. At this time, we will initiate orders for Benadryl to be given at bedtime and every 6 hours. Orders in place for loratadine to be given once daily. Does that have to be up there? No, she can put that down at the bottom, but she chose to put it right here because that's what's going on right now. So then she says that the patient continues to be have progressive dementia and is on psychotropic medication with the GDR and behavior monitoring. So if I look through this patient's medications, I don't see anything except for this guy, which, by the way, this physician is using this a lot. The newest and wildest craze that is coming out. If you're not familiar with it, get familiar with it. You'd never want to use it for a med A, but for the Aricept and Namenda, this is 10 times better. I haven't heard the spiel from the marketers, but I do know that this patient is on there. So she's addressing this issue: no anxiety, no depression, no insomnia, moods are stable. target behaviors are being monitored, and then she actually put that he's on this medication. So I'm going to remove that. So she was thinking same thing I was thinking. So now I'm going to scroll back and I'm going to say the next thing. Patient has a diagnosis of spinal stenosis, chronic pain related to an MVA in 1990s, requiring some spinal lumbar surgical intervention. This can be up in your HPI hospitalization, so you never need to put that in again. Has a diagnosis of rheumatoid arthritis, contributing to chronic pain. Orders in place for methocarbamol to be given to muscle spasms, as well as meloxicam for musculoskeletal pain. I'm going to jump right in here, which you won't be able to see because patients' names are on it. But he has got, and I think it comes under Care Cloud Novus Pro. So this patient is being followed by the pain clinic. So would I put that here? Yes, absolutely, because they're following him for pain medication. So I'm just going to put the pain management is following the patient. So much information that you get out of here. Throwing back up into your medications reconciled, I'm going to write progress note reviewed, because I sure am reviewing it right now. So she's saying that he's got a mild and ascending aortic aneurysm. So let's see if we've okay, so we've got a AAA there. Hyperlipidemia, mitral valve prolapse, rheumatoid arthritis, chronic pain, brought to the ED for persistent abdominal pain. I can see that his admit was on 5/2, and this is a 5/9 visit. So this is the second visit that he's had. He was also diagnosed with expressive aphasia with no significant underlying causes. I'm going to pop down here into the heat and put aphasia. Again, this is one of my patients that I have someone help do the dictation for. So patient admitted to staff while shopping. He had difficulties thinking what he needed to buy and difficulties expressing himself. Hospital records reviewed. Patient was diagnosed with gallstones and bladder distension while admitted. He was also diagnosed. So patient seen for pain management and physical medicine services. Patient found sitting in his room, finishing his lunch. Patient continues. Okay, so here's where I'm going to start my copying. Patient continues to endorse bothersome back pain that is currently not alleviated with medication as prescribed. Patient admits to intermittent muscle spasms that are bothersome. His pain is a 0 to 8 out of 10 and describes it as grabbing and sharp. So she's noting not only the pain scale, but the description of the pain. Patient does admit he feels therapy has been aggravating his pain. So what is our problem? What is our resolution? Therapy notes reviewed. So she's doing the same thing we're doing. Therapy notes reviewed, MAR reviewed. Patient reports good relief with Flexeril with no bothersome effects. I'm going to come back up here because she's talking about in the 90s, having surgery, rheumatoid arthritis. He's on meloxicam. He participates in therapies. And then I'm going to write as per pain management, and I'm sorry, I'm used to dictating, so give me some patience. As per pain management, patient continues to endorse bothersome back pain. So it validates the fact that you've read the note, and it also validates that you're going to be watching for this patient because the medication that he's on, 0 to 8 out of 10, he does have issues with that. So then she goes down through her note, like we go down through our note. Therapy, he has been engaged in actively participating in therapy. And I think that this nurse practitioner wrote that he's working toward therapy. So that's great. And then patient is evaluated today for the necessity of functional medicine and pain services. It is medically indicated at this time that the patient continue current rehab. We discontinue patient's Robaxin and move to Flexeril. And I'm looking, here's the Robaxin. Discontinue that. Now, so I'm gonna look, this is on 5/15, his note was on 5/9. So a little bit ahead of me on this. She did a physical exam. So under musculoskeletal, she writes.
Unknown caller.
Okay. I'm going to copy what she wrote and I'm gonna paste it, just so you can see what that looks like. Apparently I did, and I pasted it somewhere else. So I'll have to go looking for that on where I pasted that, but I'll look for that later. Okay, so under extremities, patient continues indoors, back pain that is leaving. So it didn't copy what I was wanting it to copy, so that was what the problem was. So chronic degenerative changes. Does the patient have chronic degenerative changes in his extremities? Yes, he has spinal stenosis, absolutely. Limited range of motion of upper and lower extremities, absolutely. That's why he's being followed by therapy. Limited core strength. Would you have assessed that? Would you have noticed that? I would have deleted this out of here. Pain with palpitation over the bilateral lumbar and thoracic paraspinal musculoskeletal. So if you didn't palpate, you can ask the patient, or you can just delete this all the way together. But getting good information, I think, is important. Functional level min to mod, patient has been engaged in therapy. So now I'm going to come over to the MDS, my favorite part of the whole thing. So this person is saying that he has long-term memory intact, poor short-term memory. His BIMS is a 14. And so a BIMS of a greater than 13 should be alert and oriented. Let me see. Sorry, it takes a long time, but it's worth it to find out and get your notes up, and it might just take a couple of seconds. Mood pleasant, sleeps at night. I don't see anything. No, none of the nurses or the nurse practitioners are documenting his orientation status. This one says he's alert and oriented ×3. So I would put, and let me see if I can, this is a guy. So I would put that he has grossly normal on here. I do specifically look at your BIMS every single time, because if your BIMS is different than what you're reporting, it needs to be changed. So whereas I'm changing it on this note, because this is a note that I'm responsible for, I'm wanting to make sure that this patient is alert and oriented. So here's where we change into a 99310. And was it worth it to look at the note? Yes, I think so. So participates in therapy, working, orders for BPH, urinary retention, orders for straight cath due to urinary retention, orders in place for finasteride and tamsulosin. And then she says an appointment where the urologist is currently pending. Then she mentions that the patient is at high risk for hospitalizations related to high-risk diagnosis, polypharmacy, and is dealing with a recent hospitalization on 4/29/2025. So that was the initial snippet. It carried over. I am going to delete this portion of it. We already know he's at high risk for hospitalization. It said it on note number 1, so I'm going to delete it off of note number 2. So, the weight is 173, the BMI is 26, he's on a no added salt, he has protein calorie malnutrition. He is at risk for involuntary weight loss. It does not say he has it, but he's at risk for involuntary weight loss, pressure wound development, and total protein is low and total albumin is low. So I sent this email out to somebody specifically, and it talks about the markers and severity of protein calorie malnutrition. So the patient, let me see if I can get back to the patient. The patient has an albumin of 3.3. So with an albumin of 3.3, they meet mild malnutrition. So this patient is going to need a diagnosis of mild malnutrition. So she does have a protein calorie malnutrition, but you're going to want to put a mild protein calorie malnutrition in there. So if you don't know what that is, we can turn around, we can pull our thing, and then you can say ICD-10 malnutrition, and then it will give you the severity. So what we're looking for is a mild degree. So it would be E44.0, and that would be a mild malnutrition. Why is this important? And I'm sure I've shared this before, but since we're doing this 90-minute since we're doing this video, first of all, on Saturday, and then we're trying to get our 99309s up to a 310, I'm just going to give you this right off the bat. This is from the MDS head of Aspire. Good morning. I believe there's a lot of misunderstanding about how to capture malnutrition, risk for malnutrition, or morbid obesity properly with the right supporting documentation in place. This was a memo that went out to all MDS providers, not us, MDS providers. As per the RAI manual, that's that very thick manual that they use as their Bible, as their information on how to write your MDS. It says, in order to code a diagnosis in the MDS on section I, it needs to meet two criteria. One, it needs to be documented by a physician, nurse practitioner, or PA in the last 60 days. How do you do that? Well, it needs to go on past medical history. So once you've added that to the patient's record, you have to go in, add the diagnosis, add the E43 point, whatever it was, and then you've got mild protein calorie malnutrition. That shows up on every single note because now it's in point click care and it pulls over. And then it has to have a direct relationship to the resident's current functional status, cognitive status, mood, or behave, medical treatments, nursing monitoring, or risk of death. So anything that happens, if they have weight loss, is it related to protein calorie malnutrition? If they've had a fall, is it related to not having enough? So again, weirdly enough, we're looking at albumins and not proteins because proteins don't affect protein calorie malnutrition. Just throwing it out there. This person has thrown it in there saying on 430, their total protein was 5.3 and their albumin was low, and then turned around and given them a diagnosis of protein calorie malnutrition. So they come in a little bit different. Again, it's a different computer system, but you've got your past medical history. So if you add anything to it, you just comma and add it. Yours need to be added to point click care. These pull over note to note to note. Yours do not. So if you've got a protein calorie, if you've got an anorexia, if you've got a cachexia, you've got to add that ICD-10 code to your point click care diagnosis list. I know it's a pain, but I'm telling you, this is going to be the difference between your documentation of a 309 and a 310. I'm not sure. I think that a 99309 is worth 4 points. A 310 is worth 2 points. You do a couple of those a day, you've automatically got a free visit. So it's worth it to do it. Past family history, she's got a father with Parkinson's. Then the social history. Remember that in order to count for a comprehensive history for any of this, you have to do comprehensively the assessment. So if you're trying to pull a 99309 and you don't have a surgical, family, or social history, and it all says don't know, don't know, don't know, you're not going to be able to use that 99309. So then can I turn around and find that information or ask the patient? So she's got the fathers with Parkinson's. She's got a marital status. She doesn't have to add children, but she did. Social alcohol use, tobacco use, and illicit drug use. I would have tried to get out of her a religion or a past, I keep saying her and I think it's a him, a past occupation, but obviously willing to discuss some of this. So this makes it comprehensive because it's not just drugs, alcohol, and illicit drug use. It's the rest of the story. So not sure why this isn't. I always add that. So there's vaccinations you guys don't have. Meds pop in for you. She's got vital signs. She's got a weight. No parent distress. The patient has aphasia. I just added that. Again, you can see the stuff that I add. I use in capitals and I try to put in the front. This patient has chronic urinary retention, but he's continent of bowel and bladder. So I just sucked this out of pain management's note, chronic degenerative changes, which I'm not necessarily plagiarizing. I'm agreeing, yeah, that is accurate for this patient with severe spinal stenosis. They did note that he's alert and oriented times 4. Some of them said 3. So he could be having some confusion, but I did change that back to grossly normal. Here is where you're going to see the winner chicken dinner. So you've got a patient. So in order for your patient, let me see if I can pull this for you. Okie dokie. Oh, I missed my Word document. We're getting another Word document. Give up my whole screen. Okay, now we're rolling. So, okay, so what we're trying to do, our goal in this whole video and why you're spending all of your time watching me half awake on a Saturday. So we already know we don't bill on 99307, minimal risk, nothing's going on. It's a patient that you're just spending time documenting on, and you're not going to get reimbursement. Low. 2, self-limited minor problems. No, they've got long-term chronic issues, which are either stable or not stable. So you can review labs or tests. You can put some over-the-counter medications in place, but the rationale between why we do a 99309 is a 99310 is you've got a chronic illness, or you've got 2+ stable conditions, or you've got 1 acute issue, and then you need one of the following data. So usually our data includes external discussion. So that's always our collaboration. And then, so if you've got that, and then you've got 2 stable chronic illnesses, but you've got something else, then that's okay. Your first one can absolutely be bronchitis or pneumonia. And so you could have a chronic illness with an exacerbation, or you could have 2 stable, but it's easy enough. This is the more difficult one. So I want to show you that you have to have 2 data categories. You need 2 of them. So one is the independent historian and or independent interpretation. So that's you reading a lab, or discussion or management testing with external physician source. So, and then high risk surgeries, high risk medications, that kind of stuff. I wish I had a timer so that I could see how long this is taking me. So a 99310. So You're going to review any prior notes. We already did that by looking at the pain management notes. Review of any unique test. So ordering of the test and or interpretation and or independent interpretation. So test documents and historians. So do we have prior tests? Do we need to order a test? So we're reviewing the test, we're ordering the test, and we're reviewing prior notes. Get out of here and let us look. So A, we've already got a prior note from this pain management. Number two, we've got labs that we've reviewed today. 5.9, we reviewed the 5.2. CBC, thyroid panel, TSH, BMP, SED rate. So most of them will be under here if we needed them. But now we're going to do a urinalysis and CNS. Maybe it's related to this. I'm not really sure. But we are true to our word. We said sinusitis. So we're going to come down here and we're going to see sinusitis. It's the very first one. Most likely related to Aricept therapy. Unknown on why that is, but you can see that we've already changed this person from Aricept therapy to this Dunbill. Continue loratadine, start Benadryl. So even though it's over the counter, we're doing something. The dementia, we've now changed to this, I would most likely say just because it's me. So, and then closely monitor, supportive care, cue and assist. I'm not doing that. So, we could definitely have the nurses do that, but I'm not doing that. Spinal stenosis, lumbar pain, pain is improved. SED rate is 5. That's fantastic. Continue methocarbamol and meloxicam. Remember the pain management note. It said stop the methocarbamol and start Flexeril, but it was dated on the 15th, and this is the 9th. Urinary retention, they patient self-caths, they have good personal hygiene, monitor for symptoms of dysuria, monitor urine pH. That's going to come with a urinalysis. And then appointment pending with urology. So that's a big deal on here. Hypertension, normotensive, no salt, diet added, cholelithiasis monitor. And then they put the AST and the ALT follow liver enzymes. So collaboration it has been made available. The time spent. So I'm not sure how you guys feel about this, but I'm going to throw in this snippet. So a high degree of medical decisions was required related to patients' multiple issues. So this is where I tell you to edit your snippet. So this patient not only had sinusitis, which we're dealing with, but they also had dementia that was uncontrolled because of the Aricept allergy type of a thing. They're also being followed by pain management for spinal stenosis, which is causing them a lot of issues, and that's why they're there. And then your BPH, the question then becomes, is the BPH stable? Well, we're getting a urinary tract, we're getting a UTI PCR. So that's not necessarily stable. And we're having to give them a specialist consult because we're unable to determine. We've given them the tamsulosin, we've given them the finasteride. So in my opinion, I'm absolutely going to put BPH here. Which requires frequent assessment. So you should be seeing this patient if they have any sort of Medicare, Med A or Med B. You should be seeing this patient. So this is a new snippet that I came up with. I can actually add it if that's the opinion of the team. But this is what I put after this. This visit meets criteria for a high MDM, medical decision making, related to high-risk diagnosis, because we've got sinusitis, we've got BPH with a possible UTI in symptom exacerbation and complications. Their diagnosis is deteriorating. Their sinusitis is getting worse. We're having to put them on Benadryl, loratadine, as well as their BPH is getting worse. We're having to send them not only giving them the tamsulosin and the finasteride, but we're also having to send them out, as well as data reviewed, including labs reviewed and labs ordered. So here's labs reviewed and labs ordered, as well as the review of a progress note. So I did write progress note reviewed. And then collaboration with staff, which is why it's so important. Here is my dictation thing. This, my friend, has just changed from a big long note to an important note, a 99310. So you spent the time doing it. You've done an amazing HPI on it. You've got most of the stuff in here, but are you missing something? Yes. If you have a lab ordered and a lab reviewed, pull up your miscellaneous, pull up what's going on with the patient, whether it's the physician, whether it's pain management, whether it's psychiatry, whatever you're dealing with right now, pull that note up, review that note, and then potentially, if you want me to add this snippet in there, that this patient meets criteria because what is. So I don't want you to put a diagnosis up here of silliness or not feeling well or whatever. This has to be a chronic diagnosis. If we look at here, it has to be a chronic illness with severe exacerbation. So we've got sinusitis, which has a severe exacerbation. So we're only putting a couple of things in place, but more than one med, or an acute chronic illness that poses a threat to life or body. Your other chronic illness that is progressing is absolutely your BPH. We keep having urinary tract infections. We keep needing to put them on urinary tract or antibiotics, and then we're referring them out to the urologist. I hope that helps for number one. I'm not going to add to this. We will do another one if you need to, if I find a great one. And regrettably, I find a lot of great ones in point click care, but I can't pull it over because I want to maintain the dignity of the patient and what facility they're in and the HIPAA. So if you have any questions, if you want to figure out how you can bring your patient up from a 99309 to a 99310, you've got your two labs, one ordered, one that you reviewed. Throw a note in there that you look at, please look at it. But your HPI needs to be bulky. It needs to have information that's going on with a patient. So if you've got multiple diagnoses and multiple treatments and you're following them, even if it's hypertension, you're following their blood pressure, and it's congestive heart failure and you're following their GVD edema, this is how you're going to get to your 99310. Questions, comments, let me know.